Okay. Hello, everyone. Welcome. Thank you so much for your patience as we got things kicked off today and all of our technology works. I'd like to introduce Dr. Lindheim here. Dr. Lindheim, can you please tell us a little bit about yourself and your background?
Thank you very much for having me today. I am currently in practice in Viera Fertility Center in Melbourne, Florida. I've been in practice. I know my blonde hair kind of gives me away. So I've been practicing now close to 25 years in the world or the silo of reproductive endocrine and infertility. I'm a graduate from the Philadelphia area at Temple University. I did my training at USC, former military, and I've been faculty at a number of universities and professor, most recently at Wright State University in Dayton, Ohio, and now at the University of Central Florida in Orlando, Florida.
So you clearly like to stay busy.
Yes, a little bit.
Excellent. Well, we have a list of questions prepared for you today, and then we'll have the opportunity for folks from our audience to ask questions as well at the end. So if we can get started by talking obviously about the use of fresh eggs versus using frozen eggs. So if you had a patient who was deciding between using fresh and frozen eggs, what factors would you consider in providing medical advice to them?
Well, I'm going to start it off by giving you just a little bit further background. My mentor, Dr. Mark Sauer, trained a bunch of us, and I have a huge vested area and interest in third-party reproduction. And we've been doing it since the early 1990s, where a lot of what we had done is that originally we were doing one donor to one recipient. And a lot of our experience came about it because egg donors responded enormously well, and we started doing what we called split or shared cycles. We were doing two recipients to one donor, as many as 5 recipients to one donor. And it created a lot of logistic nightmares, but it also created an enormous amount of success for people, and sort of was the backdrop to where we are today. It has taken since the 1980s, since around early 1980s, when third-party reproduction first came about. Success rates, we have, millions of children born through fresh IVF, ART-related cycles. However, the experience with egg freezing has been experimental until 2013. And a large part of that was because of our understanding of the freezing process that surrounded, and if I get too complicated, you may cut me off, but the process is something that's referred to as vitrification. Vitrification is a fascinating technique where in the old days, and still even there are programs that are doing it, the slow freezing process created ice crystals on the largest cell in the human body, which is the egg, the human egg. And when you would create ice crystals and you thawed, you would potentially fracture that egg, fracture embryos when you created ice crystals. And it wasn't until we could do a very fast snap freeze with what's essentially referred to as vitrification, we didn't have the ice crystal issue related to that. So with that, the experimental label came off in 2013. And now when you look at the utilization of egg freezing, it started with oncofertility, patients who had cancer. It started with social egg freezing, and now is increasingly finding its way into the world of egg donation, and has many huge advantages. But still, at the core root of it, we have such experience with freezing, doing fresh cycles with an egg donor and creating embryos and transferring them in fresh cycles, that success rates now are hovering somewhere between 65 to 70% in a given embryo transfer cycle. Our experience is a little bit less robust, where we're probably in the now between 5 to 10,000 million versus 1,000 babies that are born from egg freezing. So we still have a long way to go until we have completely perfected the technology. But with that, I give that background scientific information. We have a lot of experience with embryos and fresh cycles than we do with frozen eggs, thawing them, creating embryos, and transferring them back to a uterus. So when in a couple trying to decide whether they should do fresh versus frozen eggs, that's the number one factor. But really the biggest factor that I come down to is how many children do you want to have? And it's really a very, very simple question, because if somebody is thinking that they want to have a lot, a couple of children out of this batch of eggs, then I tell them that they may never get access to that egg donor again. And so either they want to purchase a lot of those egg donors, that egg donor's batch of eggs that are frozen, or they can have the whole batch that the egg donor has gone through, and thus can create, do a fresh cycle, or could even do a frozen, freeze all the embryos and come back and do a thaw cycle with those embryos. Whereas if somebody's thinking that they only want one child, you can buy a batch of 6, 7, or 8 eggs. And that's sort of the starting point. Now, it's real important for the audience to understand, people are always wondering, why are you selling 6, 7, 8 eggs? And so it's really simple math. It's very, very simple math, is that we'll start with 10 because even numbers are easy for me. But roughly around 80% of eggs fertilize. So if you take 10 eggs, that means you have eight eggs that have fertilized. So that's a donor egg. You have 10 eggs, 8 have fertilized. And essentially, the best time to transfer an embryo is when it's become a day 5, day 6 embryo called a blastocyst. And roughly about half of those make it to the blastocyst stage. So now if you're at 8, you have 4, you transfer typically 1 embryo, that means you have 3 left over to cryopreserve. So that's why if we lower the number threshold, and if you purchase 6 eggs, for example, 80% of that is 4.8, 50% of that to the blastocyst stage is about 2.4. You transfer 1 embryo, and if you do get pregnant or you don't get pregnant, you have 1 more embryo transfer for which you can go. And so like utilizing those numbers, as opposed to maybe somebody having 20 eggs from a fresh cycle from an egg donor versus having a limited pool, is something for people to put their heads around in trying to decide what is practical for them. How many children do they want? Do they want a sibling for that child? Knowing that they may not be able to get that egg donor back because the half-life of an egg donor is maybe 1 to 2, at most 3 cycles, although there are some that will go further than that. So those are important factors to think about. Does that answer your question?
It absolutely does, and a few others that we had actually, so you're very efficient.
Yeah.
One question that we were going to ask specifically is about success rates. So I know that you spoke to this. So were there other points specifically on between fresh cycles versus frozen eggs that have a higher success rate? I think you already touched on this, but if there's any other insight you can provide on that topic.
Well, it's very interesting is that the success rates on frozen eggs are very, very close to what they are on fresh. And so that's exciting. And it's very reassuring as we talk to patients about utilizing frozen eggs. So from a success rate standpoint, that's very reassuring. But again, I still think we have several more years, because not all programs who are freezing or banking eggs, it's not an all for one, everybody's equal, because some people stimulate egg donors differently. It's very different for obvious reasons from a sperm donor versus an egg donor. Some programs will stimulate an egg donor differently than others. The quality of the lab in terms of freezing, and then ultimately the quality of the lab to where those eggs are going to get shipped to is going to be very different as well. So those are variables that you can't control for all of them. And that's why success rates are close, but not quite the same as they are as a fresh egg donor cycle.
Sure. Thank you for that insight. We were also wondering about, how does the retrieval and transfer process differ from patients that are using fresh versus frozen eggs? And perhaps a better question might be, egg donors are in the mix as well, because that process might be different.
Well, classically, The classically, when you have an egg donor that goes through a cycle, we've always tried to synchronize the uterus with the retrieval of the eggs. And so when you get an egg donor and those embryos are ready to transfer about 5 to 6 days after you do the egg retrieval, you need to make the uterus receptive, and it's precisely receptive, so that once a woman ovulates, I call it this magical peanut butter. For those out there that know me, they've always heard me talk about peanut butter. But once a woman starts progesterone, this magical peanut butter, otherwise called pinopods, come out and are expressed somewhere around 6 to 7 days after a woman makes progesterone, whether on her own or whether she takes it naturally. And so if you think about that, there's a lot of synchronizing and coordinating for all of that. Of which, if an egg donor 5 to 6 days prior to your embryo transfer, I need to have sperm. So if her partner is local, that's easy. They just drop in and produce the sample. Or if they're out of town, you have to make coordination efforts to either fly in and produce the sample where they're local, and then have the sperm shipped to the destination where the egg retrieval is going to be. So there's some potential logistic timing things. Having done that for many years, I don't even think twice about it, especially when I was doing 5-way splits. I always joke, and it's a funny story, is that the first time I ever did a 5-way split when I was in New York, I had my staff in my office, and I got up I was in Manhattan at the time, and I got up and opened up my window on 59th and Madison, and I screamed out, jokingly, I screamed out, "Everyone start your progesterone today," because I felt like I was starting progesterone on every recipient in New York City, you know. And in that particular cycle, we got 4 out of the 5 recipients pregnant. But there's logistic related issues to, coordinating all of that. One of the other nice advantages with frozen or with a fresh cycle is we don't even have to do that anymore, because embryo freezing is a wonderful avenue as well. So if a fresh egg donor comes in and we have a sperm source, whether it's a partner sperm or whether it's a donor sperm, we can create those embryos. So if in the ideal world, I'd love to have embryos because I have a track record. We all have a track record with embryos. And so you can freeze them, and the freezing process with vitrification, pregnancy rates are as equal and maybe even better than they are with fresh cycles. So now if I have an egg donor, I can make embryos and I can put them in the freezer, the cryo tanks. And now a woman can come back at her convenience. The carrier, the woman who's going to, the intended parent, can come back at any time that she wants. Now, on the flip side, there are the frozen eggs. And the advantage of the frozen eggs is that you can buy a smaller cohort. It potentially is a lot less money because you're not purchasing all of the eggs. And you can create embryos, but the eggs are frozen. Now you're thawing it. So the concept on frozen eggs it's a bad analogy, but this is the only one that comes to my mind. Is like you have meatloaf, it's fresh, it's good, you freeze it, you thaw it, you freeze it again. And that's kind of the concept. All again, the pregnancy rates are they're almost as good as using the fresh cycle. So if I have to prioritize, I would do a fresh egg with a fresh transfer. I would then do a fresh egg, make an embryo and freeze it. And then, for cost related issues, because you're only buying now a fraction of the eggs, you have a frozen egg, you make an embryo, and you can either transfer it fresh, just like the other two examples I gave, or you can transfer that as a fresh embryo transfer. So we have essentially 4 different permutations that we can do. And again, the advantage of the fresh and you get all the eggs is you have everything. You have all that whole gene pool, whereas in the smaller cohort, it's potentially less money. And then you don't have to deal with disposition decisions. What happens if you got 10, 15 embryos? You don't want 10 or 15 children. I assume most people don't want 10 or 15 children. So then you have to come up with disposition decisions to be made. So there's, the yin and the yang trying to decide what's best for you. So I hope that helps.
Absolutely. So is there a difference significantly in accessibility and availability of frozen versus fresh eggs for recipient parents?
If you want a fresh egg, a fresh woman to give her eggs, you are limited based on her timetable. So there are a cadre of egg donors that Family Source, other donor agencies that have available that can go through fresh cycles. But the thing is that you're dependent on their schedule. So if she's currently doing a cycle and maybe doesn't want to do a cycle until, after Memorial Day, you have to wait until she's available. And then you're always crossing your fingers that nothing happens to her during her current cycle, or that nothing changes in her life situation, that she'll come back and she'll do that May cycle. So those are the social, is that the right word? Those are the lifestyle, not even lifestyle. Those are the day-to-day things that you hope navigate very, very well, because we're always assuming like, hey, she can do a May cycle, but you just hope that nothing happens between now and May. Whereas the frozen egg, that donor has already gone through her cycle, and now you have those and you can purchase them and you can do that cycle, whether it's a fresh transfer, freeze the embryos, come back and do it at the convenience of the recipient. That advantage is that you already have that commodity, which is the egg. So you see the yin and the yang of both.
Yes, yeah, it seems like a numbers game and kind of a balance act in a lot of.
But you know what? The nice part about it is that there's the availability to it. Mm-hmm. So that I'm not a paid consultant to Family Source consultants, but what I can tell you is that the nice, wonderful thing, because I refer to a lot of places around the country, is that if it works for you financially, time-wise, it's the perfect situation. There's lots of fresh egg donors that you can use. And on the other hand, there are lots of frozen eggs that are cryopreserved as well. So that's the nice part, is that you can go either direction. You're not limited. You're definitely not limited based on what you want to do.
So is there a notable difference in cost then between using fresh and frozen eggs?
I don't want to, in theory, because when I was running my university-based egg freezing program or split shared program, it was whether it's fresh or whether you're buying a fraction of the eggs, it was a reduction in the cost. I can't speak to Family Source consultants because I don't know what their numbers are, but at a personal level, I can tell you that if I did a three-way split, just like a fresh three-way split, I bought a third of those eggs. I paid for a third of the donor's component. So just hypothetically, I got to come up with a number here. Let's say it's $18,000 to do a whole cycle. Well, a third, or the egg donor part of it is, let's say it's 50%. If I split that three ways, I pay a third of the $9,000, and I pay for the lab part, which is my part. So there's huge advantages to that. Now here, when you're purchasing eggs, in theory, they've already gone through the whole egg retrieval process. So you're just paying a smaller component to the bigger picture. I hope that makes sense, but not knowing the finances of everybody, I don't know what they all charge. I mean, unfortunately, it is a lot of money, and you're paying an egg donor back for her services. There's the coordination of doing all of this, and there's also the IVF programs costs that are layered into it. But on a positive note is that I know Family Source Consultants does work with patients and with clients, and they are highly, highly competitive. And that is one of the personal reasons that I refer a lot of patients to them, to you.
Absolutely. So I have one final question for you, and then I think we'll open it up to the group. So what do you think is one of the biggest misconceptions about the differences between using fresh versus frozen eggs?
That frozen eggs is just as or equally efficacious, or works just as well. I think you have to be very, very careful. Like, what's the track record of the egg freezing bank that they're doing? You know, does the egg donor have a proven track record? That, you know, when you start off with 6 eggs, you can do the math. 80% fertilize, you know, 50% should make it to the blastocyst stage. And I would encourage all programs, when you are purchasing eggs, you want to ask the program that you're going to be transferring your eggs to is, what's the thaw rate? What percentage of eggs actually survive the thaw? I can't give you that. I mean, I can typically tell you that it should be 90 to 100% of eggs will survive, but it's not always. And what's the percentage of the eggs that fertilize that make it to the blastocyst stage? And not only is their pregnancy rate, what is the pregnancy rate, but how many of those embryos, extra embryos, did you get to freeze? So how many cycles did they get out of that? As you're thinking about doing egg, you're purchasing frozen eggs, that wherever you're going to take the eggs is make sure that the program has a lot of experience with egg thawing. And ultimately, you know, I mean, most labs have the ability to make embryos, but the question is do they have the skill set? Do they have a track record of egg thawing and creating, you know, good viable embryos that result in a pregnancy and also result in extra embryos to freeze so you can come back and have another baby, you know, if that. So I think that that's an important misconception, that everybody thinks that they get cryopreserved embryos out of purchasing 6, 7, or 8 eggs. I think that people need to go in with the notion of, like, if I want that egg donor, remember, you may not get that egg donor back. You know, she may move on in her life. Again, the half-life is short, so that if you're going to purchase eggs, think about purchasing eggs more than the 6 or 8. You know, identify the egg bank that you're going to buy from. If you want 2 or 3 children, maybe buy 10 or 12 eggs, you know, so that you can have potentially more chances than not to get pregnant, or to have at least transfers. To reassure everyone, whether you're a fresh egg or whether you're purchasing frozen eggs, the donors are screened exactly the same way. My concern with frozen egg donors, unlike a fresh egg donor, is that I counsel all egg donors going through, and I tell them that their eggs can be utilized for women who are 40, women who are 60. You know, I tell them, are you comfortable with this? Are you comfortable with same-sex couples? Are you comfortable somebody utilizing a family member sperm because they're a single woman, or splitting eggs? Many of these egg donors are not even aware that their eggs are going to be shared amongst multiple different couples. And in addition to that, it's really important to tell the egg donor, when you're doing egg freezing, that she needs to be aware that she's relinquishing all of her rights. And if she has any issues with a couple, if you get pregnant and now they want to donate those embryos to somebody else, is she comfortable with that? And I think that those are really important elements that a lot of programs aren't taking into account, because we're so used to doing an egg donor. For my wife and I, you know, she may not know us, but that it's a one-on-one situation as opposed to multiple different directions you're going. You need to tell them and make sure that they're comfortable with it, because you don't want them coming back and saying, you never told me that. So those are important things I think are undervalued or not even thought about. That makes sense?
Those are some really important considerations. Absolutely. We do have one question from the group that I wanted to share. So pause on my questions for a second. You've mentioned that the success rate between fresh and frozen eggs is almost the same. So can you give kind of even a closer approximation or more specifics on the differences in success rates specifically? Like, are they, how close is almost, I think, is a better way to ask the question.
You know, in a real simple answer, they're pretty close. They are pretty close. I think that in the back end of it, though, is how many embryos were you able to cryopreserve? So the, you know, fertilization rates, you know, again, we only purchase eggs from, you know, well-known, you know, egg freezing programs. They, you know, and we also want to make sure that you have some kind of level of guarantee that if the eggs don't survive a thaw, that you'll be able to, you know, recapture more eggs in the back end. Or what happens if the embryos don't result, you know, in good, like poor quality embryos? Is there some level of guarantee? But I think that the bigger question is like, how many transfers that they ultimately get, because you know, that's important. But the pregnancy rates are very, very comparable, you know. So you know, I don't want to jade people. I do know on a national level that fresh embryos and frozen embryos still result in higher outcomes than they do with frozen eggs.
Thank you. And for folks watching right now, just as a reminder, you can use the Q&A feature to submit a question and we will ask. So we have another one that just came in. So if I freeze my eggs, how long can they remain frozen and still be viable? So do they lose effectiveness as time goes on?
It's an excellent question. In the animal models that have been looked at, embryos appear to lose after about 6 to 8 years some level of viability. There's not a lot of literature in humans. We are actually trying to track that with donated embryos, and it does not appear that embryos that are cryopreserved more than 10 years lose their effectiveness compared to embryos that are cryopreserved now. Although that's going to be a little bit biased, that data, because the technologies were a little bit different. We don't have a real long track record because, you know, egg freezing has really only started taking off since around 2013, and many women have not come back to utilize those eggs. So I can't give you a definitive answer on that. Outcomes do appear to be excellent. And again, it depends why you're freezing. Is it for social egg reasons? Is it for oncology, cancer related issues? So still important to look into this and to try to identify this downstream, you know, because we don't quite have the answers.
Right. That is very helpful. We have one more for you. So if someone is over the age of 40, doesn't have good eggs on their own or viable eggs at this point, does using an egg donor at over 40 have any less success? Does that typically matter?
No, I just want to see if you can see my piece of paper. So this is, I'm going to just draw this out here. So this is a woman, 30, 35, 40, 45, 50, and this is the pregnancy out. I'm going to just draw, I'll explain this. So this is a woman and her uterus, and this is the egg. Okay.
Okay.
So what you can see in this graph here, it's probably backwards. It at least looks backwards to me. But
No,
you can
it's
see,
straight on for us. We got it.
so what you can see here is that the uterus doesn't age. So it doesn't, if you take this young woman's egg and you put it into this uterus at 50, her chances of success are the same as she was when she was 35 using a young woman's egg. Now, pregnancy rates subtly start to decline after the age of 50 if you use a donor egg. There's an increase in hypertensive disorders, preeclampsia, and gestational diabetes. And that just may be because just like we have an increased risk in heart disease, there may be an increase in uterine disease as you get older. There's more fibroids, more other pathology. But if you look at this is essentially what it looks like into a woman into her 50s. And we know in India, they are getting women pregnant into their 70s. And I know in the Bible, Sarah got pregnant at, I think, 99. So there had to be an egg donation center in biblical times as well. But the uterus, overall, you will see a slight decline after 50, but it remains pretty much like this. So the answer to your question is, using donor eggs at my age have less success? No, provided you have a normal uterus. And uteruses, fortunately, can be fixed. Unfortunately, the egg is sort of the holy grail of trying to fix the advanced reproductive age woman's egg.
Wow, that's fascinating. Learned a lot here. So we have a few more audience questions that I want to get to. So if someone has embryos that are over 13 years old that were made with grade B eggs from a donor, should they be disposed of at this point, or what would your advice be?
Well, first of all, when you say dispose, there are, that's another misnomer in our industry. There are a number of options that can be done. First and foremost is that if you want another child, absolutely would, say you should absolutely give a try with this egg donor. The one thing that can be done when you say grade B eggs from a donor, they are now embryos. So the question is what's the quality of the embryos? And there's a good chance that maybe they're not blastocyst embryos. Maybe they're what we call cleavage stage, which are called day 3. And you could grow those embryos out to day 5 or day 6 and look at their viability before you do an embryo transfer on day 3. So again, without knowing all the information, I would say that maybe they're day 3 as opposed to the newer technology, which is now day 5 or day 6. They're not grade B eggs anymore. They have a quality in terms of their embryos. So they would have a score based on their inner cell and their outer cell mass. But that's option number 1. And then, of course, if you are done your family bearing, you don't have to dispose embryos. You can donate them to research. You could donate them to quality assurance in the particular lab that you're at. If they're doing, the junior people are practicing on things, and then you can always have what we call compassionate transfer. If you were not comfortable disposing eggs, you can place them in at a suboptimal time into the uterus. So there are lots of options. So I don't want you to think that you have to dispose them, but at the end of the day, I would say that they are still very viable.
Very helpful. I think your comments have been very reassuring, both in this answer and the one prior to a few folks on the webinar now. So thank you. I'm also curious about, so your experience has led you to infertility clinics around the world. So have you noticed any interesting cultural or systemic differences between the reproductive endocrinology around the world internationally?
Yeah, I have. I've worked I helped to set up a center in Jiaotong School of Medicine in Shanghai, China. Wonderful people. This was just in the last couple of years. They do approximately 12,000 IVF cycles a year. They start efficiently at 7 in the morning, and they're done all retrievals and transfers by noon, which is just absolutely unbelievable. The turnaround time is just amazing. But they do things very differently than we do here in America. Some things that would scare me to death if my wife was having a retrieval there. I had to sneak silver nitrate back, which is a cauterizing thing that you can put on the vagina if there's a little bleeder there. And I asked, so what do you do when somebody's bleeding? Oh, we just watch it. I'm like, oh, well, that's kind of reassuring. They have up-to-date technology and probably some things that are more advanced than ours. They don't do third-party reproduction over there. It's illegal. The ability to do clinical research in the United States takes about to do a randomized clinical trial to see something that's truly efficient, it would probably take us 3 to 5 years to be able to run that trial. And we'd have to do multiple centers. There, the volumes are so big that they can run a randomized clinical trial and get it done in less than a year. So it's absolutely astronomical. And then it is one of the most, how do I say this, most asexual part of the world. Many patients would come and they want to do IVF because they were too busy. They were working, traveling all over the place. They just didn't have time to create a family naturally. So there was a lot of IVF for that particular reason. And so it just absolutely shocking to me. So that's among a few things that I found very different. It's a wonderful culture. I learned a lot and I got to travel. And my wife and I had just the greatest experience, and I'm glad we did it.
Thank you for sharing about that. It's very interesting. Well, I know we're coming to the end of our time here, so just wanted to wrap up with any last thoughts that you had, maybe that you haven't gotten to share, or other aspects of the work that you'd like to reiterate for us.
Well, again, I would say I have zero interest in family source consultants, but I think that what's really important is that as you embark into third-party reproduction, it's a world that is seemingly unnerving. It's unnerving because, you know, the basic expectation in life to have a family is taken away from you, and that's unnerving to many, many couples and to patients themselves. And first of all, third-party reproduction is, as I was taught by my mentor, is a fabulous, wonderful way to create a family. Not that adoption is not wonderful as well, but to carry some of the genetic pool of your partner, to go through the birthing process. And you want to identify and find not just the IVF program that's going to take good care of you and help you get pregnant, but you want to have some people help navigate that process, because it's unnerving, it's expensive, it's draining emotionally with your partner, financial resources, and you want somebody that is going to be there as an advocate for you. And so there's a lot, I know a lot of people in the industry, I know a lot of groups in the industry, and as you pick the group that you're going to work, I'm not putting a pitch in for me as an IVF program, as you are trying to identify the egg donor source or site, that program that you want to secure your eggs from, family source consultants is one of the top. So, and I've been doing this for a long time. So everyone is very accessible, and they will hold your hand all the way through the process. And you don't find that very often. So
absolutely, thank you. I know we have one more question that just came in, and we have 1 more minute. So I'm wondering if you could sneak in this one last question real quick. Is that okay? So the question is, if someone wants to do fresh egg retrieval without IVF usage, if they're okay to do multiple retrievals, what are your thoughts?
They want to do fresh egg retrievals with any, yeah, I mean, that's all possible. Just the downstream effect of that is it may cost you a lot of money to do that, but certainly you can, that's any or all possible. That you can do banking on multiple cycles. Absolutely.
We appreciate the insight as always. Thank you so much for your time, Doctor. We can appreciate your wisdom and experience as you're helping folks, make some very big, important decisions in their lives. So thank you.
Thank you. Thanks for having me. I greatly appreciate it.
Absolutely.
Have a great day.
Everyone.